Hi everyone. This video is going to be on visual field defects management. Um, okay, this lecture is for OPT3475, low vision and further optometric care. So in the previous lectures, we already have a look on what are the assessments to be conducted on the patient, such as history taking, visual acuity taking, refraction, and all the assessment that is related to low vision. What are the assessment that needs modification in terms of the assessment that we perform on the patient? They already discussed in the previous lecture. So now we are looking at the management part. Okay, so we started off with low vision device that is available for distance and also for near. Okay, and the complaint that this patient, usually visually impaired patient or low vision patient, it doesn't end only with blurriness at distance and near. Okay, a lot of activities that they cannot do because of the vision problem that they are having. And in terms of blurriness, we can actually help them with the devices. Okay, if let's say that cannot be overcome, then we have non-optical devices where we do some changes in the for the activities that they do, what kind of adjustment that can be done so that they're still able to do the activity they have been doing or they wish to do. Okay, so this could be done with non-optical devices. And with the advancement of technology, there's also existing electronic devices that we have that enhance um, uh, the the activities that the patient wants to perform. Overall, all of these managements are very limited. It's depending on the ocular condition that the patient is having and how severe it has actually damaged part of the eye. Okay, that actually contribute to the success of the management that we provide to the patient. Okay, so now we're going to look at the next part of the um, management. Okay, so it is not only ends with a blurriness or environmental change and all that that is needed by the low vision patient, but also they come with complaints that is related to visual field. It can be the peripheral visual field defects and it can be the central visual field defects. Okay, and it is important for us to ask questions that can actually give us some information on what type of visual field defects the patient could have by just questioning them during the history taking. So one question that can be asked to the patient, or few questions that can be asked to the patient, is that lead to the idea whether the patient is having visual field defect management. Is number one, if let's say it is related to central visual field problem, you may ask patient whether they have any problem, okay, in recognizing faces or not. Okay, why do we ask that question is if let's say the patient is having some a problem in the foveal or the macula area, what will happen is the image will be blurrier at the center comparing to other parts of the visual field. Okay, and also like a distortion only at one portion in the center. So since this the macula part is responsible for the detailing that we see, that gives us the clarity of the image that we see when we are looking at an object. So it is important for the macula to function normally. When it loses its function, then it started off with the complaint of blurriness in the beginning, and then they will have like some distortions. Okay, when they're looking at certain object, trying to focus and get the details of the object that they're looking at. And then at one point of time, when it gets severe, then they will have like a central scotoma where the center part is like kind of shut down already because of the damage that is actually the patient is having. So this is the stages of the central visual field problem. So what are the activities that will be affected when the patient is having central scotoma? Okay, or any related visual field defects at the center part is recognizing faces. And then if let's say they need to read something, so they tend to miss the words while they're reading because while they're reading, my name is Indira. Maybe the is missing, or the name and is missing depending on the size of the scotoma. Okay, so this kind of question can be asked to the patient. Okay, do I have a problem in recognizing faces, or when you want to look at some details, you feel like only at one certain part at the center that it is actually blurry or not clear, or the contrast is not good. So that will give you an idea that whether the patient is actually having this or not. The next one is the question that can be asked during the history taking is whether they bump into things, while they're walking, or if let's say somebody approaches them, from the side, not from the center, then do they get startled because of that? And also questions that do you have like a difficulties or no confidence when moving around at night because you couldn't see things at the side. Okay, so this kind of things can actually give you information whether the patient is having any defects, peripheral visual field defects or not. Because peripheral visual field defects is actually caused by the degeneration of the cone, which leads them to have this problem. Okay, so when the side vision is affected, what will happen is while a patient is moving, okay, because if there is a scotoma at the side, okay, they will not be able to see if let's say somebody approaches from the side. Okay, because this area is missing and this area is missing. Or if let's say the patient is having like anything drop on the floor and they have to pick it up, then it's difficult. They have to turn their head more so that they can actually know whether it is actually on the floor or not, because of the peripherally, there is a scotoma which is blocking their vision. Okay, and bumping into things while they're walking because they don't know what is actually placed at the side. If let's say it's a unfamiliar places. So they tend to actually bump into things. And the question has to be, when it comes to this mobility and visual field, peripheral visual field defect, right? The question has to be refined, saying that whether the patient is having any problem moving around, okay, and bumping at things at unfamiliar places or not. Why unfamiliar places? Because usually in familiar places like houses and all that, right? Even if let's say we close our eyes, we still can move around. Okay. However, if let's say at unfamiliar places, we don't know what is awaiting for us from the side or from the front, we have to scan first to know the information, to get confident in moving around, okay, in unfamiliar places. But for patients who are visually impaired with additional peripheral visual field defects, right, they would have this problem. So that two questions, okay, will give us an idea of what is actually happening to the eye of the patient that is related to visual field defects. Okay, so that's how we relate the assessment to the finding, and how do we manage that. Okay, so now we're going to look at, as I mentioned earlier, these visual field defects. There are two types. One is central, another one is peripheral. Okay, so as I told you earlier, the center will be, like if let's say we look at this picture, right? This is the original picture of the kid. So if let's say a normal person like us looking at her, okay, all the features will be clear for us. If let's say we are looking at the eyes, it's clear, although this picture is not HD, but we know the details. Okay, she has a nose, she has a, plenty of teeth. Okay, so we can see all the details. But if let's say patient is having central scotoma, it will be faded only at the center. If you see the sides, right, it's still the same. Only the center is actually, fading, okay, or being black. Okay, if let's say central scotoma, this total face will be actually black for the patient when they are looking at this girl because of the central scotoma. Okay, so if let's say the patient is having central scotoma, what is the management for it? Okay, so the management for this is eccentric viewing technique. Eccentric viewing technique means, okay, if let's say we do have a macula, right? The maybe in macula, the side of the macula is still intact and functioning. So we are trying eye from the central fovea towards slightly towards the peripheral part of the peripheral part of the macula, so that they can actually turn their eyes to one side so that we can utilize the remaining healthy macula. So that's the idea of this eccentric viewing technique. But it is very difficult to make this happen. Okay, to practice, you need a lot of training, and age is a factor, motivation is a factor. The person who wants to be trained with this eccentric viewing has to be highly motivated, okay, and they should be slightly younger, because if let's say elderly people, right, the motivation is very low, okay. So that is eccentric viewing technique, okay. That's the one option that we have, okay. um, we so we're going to look in detail what is this eccentric viewing technique, okay. So basically this eccentric viewing is a technique used by the people with central vision loss. One thing that you have to remember, do we have to train all the patients who have the central scotoma with this eccentric viewing technique? No. It is depending on the need of the patient, age of the patient, motivation of the patient, whether they want it or not, and also the task that they want to do. This actually determines whether there is a need for this eccentric viewing technique or not. And another thing that you have to remember, mostly patients who have central scotoma, right, they will automatically will have this um, eccentric view. The reason why is when they are looking at distance, right, they know that with the central, they cannot see the details. For example, the kid's face, right? They cannot see the details. So they will be like actually checking their self. Okay, if let's say move to the right, move to the left, will that actually, give me a better vision or not? So when they know that when they turn the eye slightly to the left, they can see, more information. So they will tend to use that eccentric viewing. Okay, so that can be actually, that is the idea. So usually when they will have like a habitual eccentric viewing already. Okay, but if let's say the patient is still new, just got to know or just diagnosed with the central scotoma, then when we suggest, they haven't start using the eccentric viewing, so we train them. So once, if let's say the patient is already having an eccentric view, then we do not train the patient because they already know how to do it. Okay, so if let's say maybe when they're looking at distance, they can see things all you know better with the eccentric view. But usually for near, right, they don't habitually actually get into that, because most of our activities is involving distance vision. Okay, so when it comes to near, right, reading and all that, right, it's lesser time that is being spent. So when it is lesser time, so it is not happening habitually. While for distance, because you're using it all the time, so then you get you the patient will try to get adapted to the eccentric view position. Okay, so now the focus is how do we train the patient who is actually having central scotoma. Just give me a moment. Excuse me. So now the lecture is going to be focused on how do we train a patient who is not using the eccentric viewing technique yet. Number one. Number two, we are going to train patients who are already using eccentric viewing technique for distant, but they don't know how to apply that for near. So that will be the two groups that usually we'll train in the clinic. Okay. So now we're going to look at the method of training these patients with central scotoma with eccentric viewing technique. And please do remember this eccentric viewing training, right? It is not like 1 day, 2 day program. Okay, sometimes it takes months for us to train the patient, depending on the motivation, the attitude of the patient. Okay, how compliant are they, when we give them exercise and do this, right? So all that, it's a contributing factor. Okay, it's not solely because of the how severe, is the arm. Okay, so this is known to be the PRL. Okay, so when you actually turning your eye or taking fixation other than macula, so it is called to be the preferred retinal loci. That means you are shifting your gaze from macula to the peripheral retina areas. Okay, peripheral macula areas, in which, okay, the person looks slightly away from the subject in order to view it. Okay, it can be up down, right, or left. So it is not only restricted to horizontal movement only. It can be up and down also. Okay, so when they move the eye to one side, which is still healthy, the macular area, the peripheral macular area, they can go for, if let's say they're able to do it, then they can actually go for this train. Okay, so basically we are using the peripheral macular area, which is still healthy, okay, to see the detail. Okay, another thing that you have to remember, okay, after I explain this, right, you would have idea that eccentric viewing training is something that makes things clearer for the patient. No, that understanding is wrong. When it comes to eccentric viewing training, right, we are trying to make patient to have more information. Okay, so what you do is you just put to experience this, just put a sticker, a cross sticker at one place, and then on a wall or something, and then put a toy or anything on the other side. Okay, stick it on the wall. So what you do is, further by, maybe uh, 30, 40 centimeter within that range, the distance between the cross, the target cross, and also the toy that we stick on the wall. Try to actually make the person, or try to make yourself to look straight to the cross that is given. Okay, so while looking at the cross, try to make the details of the toy that is being stick slightly far away from the patient's eye. Okay, so while looking at that, you will understand what I'm trying to say, that it is only providing you information, but not the real image as how you could see, using your central vision. Okay, so that one you have to remember, because you try that and then you will understand better. And also, I have to let you know that the clarity is the best when you look through your fovea, because once the fovea area is actually crossed, okay, towards the peripheral side, right? Okay, so what will happen is when it is actually moved by 1 mm also, okay, I mean the eye move from the uh not the eye, that means in the fovea and macula, right? The fovea and macula, it's highly concentrated with cones, which is actually helps us to see things clearly. Okay, so they are there. Okay, what will happen is when it is actually moving from fovea to the peripheral macula, right? It loses its density of the cone, actually loses when it is actually going to the side areas. So when the cone's density is lesser, the clarity that the patient is going, the clarity of the object that patient looking at will be affected too. Okay, so it's not going to be as clear as your fovea or macula. Okay, but it helps us to actually gain some information that what is actually in front of them. Okay, so that's why we do train patients with um, what do you call this, eccentric viewing train. Okay, okay. Next is, okay, another thing that you have to remember when it comes to this um, eccentric viewing training, it is time consuming. As I say, it is not like a 1 day thing or within a week. No, it takes a longer time. It depending on the motivation and also the age of the patient. The cooperation is very, very important. If let's say they're compliant, then definitely, we could see some good results. But if let's say they are not, okay, because it's taking a lot of time, then we won't see any outcome of it. Okay, so it is time consuming. Okay, different people need different time. Different people have different understanding. So to get them to reach, get them to be, fully trained, it takes time. So both patient and also, practitioner has to be patient enough to teach and to learn at the same time. Okay. Next is need a lot of rest. Okay, because it's very tiring to you, for you to take an item and look at that, look at an object or look at some environment using that eccentric view is not easy. It's difficult. Okay, so they need a lot of rest, cannot be doing continuously any activities for, you know, 2 weeks, 3 weeks, and all that, right? So it has to be the activity is going to be, planned ahead. That this week we're going to do this, then the next one is going to be this, third week is going to be this. So we have like a plan on how to do it. But whatever that you ask them to do back at home, exercise or something, they need a lot of rest. They cannot do for continuous 20 minutes and 30 minutes. No, they just do it for 2 minutes or 3 minutes, then they would be good enough to train them. 2 to 3 minutes is the maximum training that we provide to the patient on daily basis. Cannot be like 3 hours, 4 hours, 5 hours, and all that. Okay, will not make a good vision. Will not make vision as good as the prior macular disease. So as I already explained, the center part is concentrated with cones. So once it moves from the fovea to the side, it is actually, loses its density of cone, which is also affecting the detailing, okay, of any image that we see. And the next one is helps to maximize the use of residual vision. Okay, this is what we want. Okay, help to maximize the use of residual vision, but not in making the vision in good with good clarity. Sorry, okay, but it is actually to maximize the residual illusion, at least to get some information of the object that they're looking at. Okay, so before we move on to the assessment, we'll continue the assessment in the next video.